To open the next session, please welcome Dr. Ellie Villegas, past president of the Philippine Society of Medical Oncology and the section head of the Hema-Onco Unit at Perpetual Succor Hospital, Philippines.
Good evening, ladies and gentlemen. Our next lecture is entitled Mechanisms and Challenges of Cancer Chemotherapy Resistance, No Molecular Players. Our distinguished speaker is Professor Ravindran Ankathil, Director of Cytogenetics Laboratory at the Human Genome Center, University Science, Malaysia. He received the VIFRA 2015 Lifetime Achievement Award. He also had international fellowships at the UICC, WHO, IARC, and NIH. Ladies and gentlemen, help me welcome Professor Ravindran Ankathil.
Hi, very good afternoon to all of you. I am Ravindran Ankathil from University of Science, Malaysia. I hope all of you are doing well during this coronavirus health crisis and all of you are keeping safe. Before moving to my lecture, I would like to thank the organizers of AOS2020, especially Dr. Corazon, for inviting me and providing me an opportunity to speak in this AOS2020 conference. I feel privileged and honored. Thank you. So in the next 20 minutes, I'll be talking about the mechanisms and challenges of anti-cancer drug resistance. I'll be talking about some of the already known mechanisms as well as some of the recently detected molecular mechanisms. So what is anti-cancer drug resistance? Anti-cancer drug resistance is the reduction in the effectiveness of anti-cancer medications due to the generation of drug-resistant cells in the tumor tissue, which arise from different means of mechanisms. This may lead to the drugs being unable to exert a full anti-cancer effect. As a result, a small population of drug-resistant cells continue to proliferate, ultimately causing tumor relapse. Thus, anti-cancer drug resistance is the main obstacle to long-term effectiveness of cancer treatment and the major reason for failure in cancer treatment. There are numerous anti-cancer drugs available in the market today. The manner in which they attack cancer cells differ according to their classification. The major classes of anti-cancer drugs used in cancer treatment are broadly classified into 4 groups. These are conventional chemotherapy agents, mainly cytotoxic drugs, then targeted agents, hormonal therapies, and then biological therapies. These drugs are used to treat a wide variety of cancers, and these drugs come from different families of chemotherapy drugs. So, anti-cancer drug resistance is not confined to one family of drugs or one type of cancer. So, some of the drugs that are most often associated with resistance are included here. For example, paclitaxel, docetaxel, doxorubicin, etc. Actually, there are 2 types of anti-cancer drug resistance based on the nature. One is known as intrinsic resistance and the other is known as extrinsic resistance. Intrinsic resistance is the innate resistance that exists before the patient is exposed to the drug. For example, intrinsic resistance is commonly seen in the case of hepatocellular carcinoma, malignant melanoma, and renal cell carcinoma. Whereas extrinsic resistance is the resistance that is acquired later. That means the patients initially show desired response, but they later acquire resistance. This slide shows the various anti-cancer drug families and their known mechanisms of actions. In this paper by Pan et al. 2016, the known possible mechanisms of chemoresistance in cancer cells are beautifully shown. These include reduced intracellular activation of anti-cancer prodrugs or enhanced drug inactivation by phase 1 and phase 2 enzymes, elevated drug efflux, alteration of drug target, enhanced DNA repair, tumor cell heterogeneity, and then deregulated apoptosis and autophagy crosstalk in the cancer cells. Coming to drug inactivation. It is well known that metabolic activation is needed by many anti-cancer drugs, and these anti-cancer agents undergo metabolic activation which result to acquire clinical efficacy. However, cancer cells inhibit this metabolic activation, which results in decreased drug activation. So, this inactivation of anti-cancer agents lead to the development of resistance to anti-cancer agents. The next one is increased efflux of the anti-cancer drugs. This is one of the most important and well-studied mechanisms of anti-cancer drug resistance. How this happens is because elevated efflux of anti-cancer agents leads to decreased intracellular drug accumulation. So this will lead to the failure of therapy. In this regard, transmembrane efflux transporters, mainly ABCB1, ABCC1, ABCG2, are highly involved in the acquisition of multi-drug resistance to cancer therapeutics. The next one is alternation of drug target. We know that targeted therapies block the growth of cancer cells by inhibiting specific target proteins involved in tumor development. Thus, alternation of drug target due to some mutation or due to amplification by epigenetic alteration, this will result in the development of resistance to the targeted drugs. Typical example is seen in the case of non-small cell lung cancer, where the T790M mutation on the EGFR gene results in the resistance to tyrosine kinase inhibitor drugs erlotinib and gefitinib. Then another mutation, that is T797S mutation in the EGFR, causes resistance to the third generation tyrosine inhibitor osimertinib and ruxolitinib in non-small cell lung cancer. So because of this resistance, fourth generation tyrosine kinase inhibitor EA1045 targeting both these mutations have been developed, and that is in use now for the treatment of non-small cell lung cancer. Another example is in the case of chronic myeloid leukemia, where BCR-ABL mutations cause resistance to the first and second generation tyrosine kinase inhibitor, for example, imatinib, dasatinib, nilotinib, bosutinib, etc. Yet another mechanism is DNA damage repair. We know that increased DNA damage repair activity will lead to increased resistance to the anti-cancer agents. So that will also cause resistance to those drugs. Next one is deregulated apoptosis. Deregulated apoptotic signaling, particularly the activation of anti-apoptotic systems, allows cancer cells to escape apoptosis. This will lead to uncontrolled proliferation, resulting in therapeutic resistance and recurrence of cancer. An example is the mutation of the P53 gene, that is cell cycle protein P53, which result in the failure of cancer cells to apoptosis, and that will result in development of resistance. Yet another factor is tumor heterogeneity. We know that a subpopulation of cancer cells with various genetic makeup coexisting in the primary tumors, a condition known as tumor heterogeneity. These clonal variants have different sensitivity to chemo or targeted drugs, so that a portion of the tumor and those less sensitive cancer cells would survive. So these resistant clones proliferate and grow, and tumor would recur with the different cell composition portions that are insensitive to these initially treated drugs. And also in a heterogeneous population of tumor cells, drug-resistant tumor cells can transfer microRNAs by exosome to drug-sensitive tumor cells and induce resistance to them. This type of resistance is seen in the case of ovarian cancer, renal cell cancer, breast cancer, chronic lymphocytic leukemia, etc. Now we move on to the some of the new players involved in mediating drug resistance. The first one is epithelial mesenchymal transition, known as EMT. Epithelial mesenchymal transition is a process during which epithelial cells lose their attachment to each other and gain the characteristics of mesenchymal stem cells. So epithelial mesenchymal enables the tumor cells to gain resistance to anti-cancer drugs and evade drug-induced cell death. In this regard, Overexpression of the EMT-inducing transcriptional factors such as TUST, SNAIL, SLUG, ZEB, and FOXC2 are known to induce drug resistance. Thus, epithelial mesenchymal transition also plays a critical role in development of drugs, resistance to anti-cancer drugs. Then tumor microenvironment, TME. Tumor microenvironment is comprised of normal stromal cells, extracellular matrix, several soluble factors such as cytokines and growth factors. These components, along with various cell adhesion molecules on the cell surface, fibronectin, collagen, laminin, and integrin present, together with the acidic pH developed by the cancer cells, mediate resistance to anti-cancer drugs. This kind of resistance development is seen in the case of breast cancer, small cell lung cancer, prostate cancer, and some of the hematological malignancy, etc. Next molecular player is cancer stem cells. The cancer stem cells also cause resistance to anti-cancer drugs. Although successful cancer therapy abolishes the bulk of proliferating tumor cells, a subset of remaining cancer stem cells can survive, and they can promote cancer relapse due to their ability to establish higher invasiveness and chemoresistance. These cancer stem cells are surrounded by a complex group of cells that we call as cancer stem niche, which secrete multiple factors promoting not only cancer stem cell survival, but also drug resistance. In this paper by Fee et al. 2018, they have described the various mechanisms by which the cancer stem cells contribute to resistance. So, in order to survive during and after therapy, these cancer stem cells display many responses, including EMT, self-renewal, tumor microenvironment, quiescence, epigenetic modifications, multi-drug resistance, and so forth. So by all these mechanisms, the cancer stem cells are capable of bringing about resistance to the anti-cancer agents. Then epigenetic alterations. Some of the epigenetic alterations commonly seen are DNA methylation, histone modification, chromatin remodeling, and then non-coding RNA related alterations. Among these non-coding RNAs, microRNA and long-coding RNAs have been found to play significant roles in mediating resistance. MicroRNAs are small endogenous non-protein coding RNA molecules, approximately 18 to 24 nucleotides in length, and this aberrant expression of microRNAs is considered as another mechanism of anti-cancer drug resistance. This picture shows some of the selected microRNAs which have been demonstrated to alter the pathways, including drug efflux, alterations in drug target, DNA repair, cell cycle regulation, and evasion of apoptosis, and thereby cause resistance. This is another illustration by Wang et al. In 2019 regarding the how the microRNAs bring about resistance for anti-cancer agents. In this paper by Mansouri et al. 2017, they have described the microRNAs, their targets, cancer, and the drugs involved in the anti-cancer drug resistance. Some of the examples are shown here. There are specific microRNAs involved and the targets, and in the tumor in which they develop resistance, and these are the drugs that will be subjected to resistance. This is another paper by C et al. 2019, in which they describe the role and mechanism action of several microRNAs in cancer drug resistance. A lot of examples are shown here. So how these microRNAs mediate drug resistance? There are several mechanisms. These microRNAs mediate drug resistance by regulating genes involved in apoptosis and autophagy, anti-cancer drug genes involved in anti-cancer drug metabolism, drug targets and DNA repair, GSS biosynthesis, cell cycle checkpoints, epithelial mesenchymal transition, and cancer stem cells. So, as microRNAs regulate genes involved in drug response, impairment of candidate microRNAs affect the sensitivity of cancer cells to drugs, and this will lead to the acquisition of resistance to anti-cancer drugs. Another recent factor which bring about resistance is exosomes. Exosomes are small liquid bilayered nanomolecules secreted by the luminal membrane of the extracellular vesicle bodies, which carries various biochemical and genetic information. These exosomes also cause therapy resistance in the recipient cells by transferring microRNA, long non-coding RNA, DNA, lipids, and proteins, and thus mediating cell-to-cell communication. They also distribute proteins that cause decreased apoptosis and anti-tumor immunosurveillance and increased DNA repair and stemness in the recipient cells. Also, they transport multi-drug resistance transported to the recipient cells or integrate them in reverse orientation in their membrane to decrease intra or intracellular drug concentration. Also, these exosomes function as mediators of tumor stroma interaction and also of epithelial to mesenchymal transition. Thus, chemotherapy response and outcome of cancer patients are dependent on multiple redundant diverse biological processes and molecular mechanisms. Several factors, including genetic and epigenetic events, extracellular segments, etc., that are involved in the activating pathways and which modulate chemotherapy resistance in the cancer cells have been identified. And in this diagram, in the paper by Wong et al., 2019, all these factors are clearly described, are illustrated. It's a beautiful diagram showing all these factors. Finally, the importance of next generation sequencing in drug resistance. Next generation sequencing helps in deciphering the genetic mutation landscape in cancer cells and identifying genetic alterations relevant to cancer initiation, metastatic potential, and anti-cancer drug resistance. Because next generation is capable of sequencing the whole genome and the whole exome of the cancer cells. So it's very, very helpful in the field of oncology. In this regard, liquid biopsies, especially circulating tumor cells and cell-free tumor DNA, are important. NGS technology has been used to monitor the changes at the circulating DNA levels in peripheral blood and in the dynamic changes of drug-resistant genes. What are these circulating? What are these liquid biopsies? Liquid biopsies are a non-invasive blood test that detects circulating tumor cells and fragments of cell-free tumor DNA, that is ctDNA, which are released into the bloodstream from the primary tumor and from the metastatic sites. So, NGS technology is capable of monitoring the changes on the circulating tumor DNA levels in the peripheral blood and in the dynamic changes of the drug-resistant genes. So, dynamic changes in the resistance can be sensitively monitored by this gene variation status. So, circulating DNA analysis by NGS may illustrate the complex and heterogeneous molecular mechanisms of drug resistance. For example, Cavo et al. 2020 monitored genetic alterations in the circulating DNA in 43 colorectal cancer patients undergoing chemotherapy combined with the targeted therapy using cetuximab, apatinib, and trastuzumab using the 605 gene NGS panel. They detected high frequency of mutations in P53, APC, and KRAS as markers of response, whereas alterations of mutations in BRAF and AMER1 were detected as resistance markers. So, sequencing of circulating DNA using NGS is a recent innovation for monitoring relevant molecular changes that may be deriving disease progression and treatment resistance. Other examples are ESR1 gene mutation, which cause resistance in breast cancer, then EGFR T79M mutation and amplification that arising during gefitinib or erlotinib therapy in non-small cell lung cancer. These are all readily detected in the circulating DNA using NGS. So another example is rising concentration of circulating DNA in the plasma as assessed by NGS-based mutation detection is associated with a metastatic relapse in the following months. So NGS of circulating DNA could be used to identify patients at high risk for clinical relapse with the aim of providing more aggressive or targeted therapy. Of course, still there are challenges. So, identification of drug resistance mechanisms in cancer patients and the technical know-how on how to bypass these resistant mechanisms still remain as challenges. This is mainly due to the high heterogeneity among tumors and also because of the high complexity of the resistance mechanisms. So, more systematic, in-depth approaches to identify these mechanisms, synthesis of new drugs, and developing strategies to overcome the complex phenomenon of resistance are needed for individualization of treatment and improved response of cancer patients to anti-cancer therapy. That's all. Thank you very much for your kind attention. Thank you.
Good evening, ladies and gentlemen, and thank you very much for joining us here at the AOS at the session on mechanisms of cancer chemotherapy resistance, new molecular players. And I'd like to thank personally Professor Ankathil for this very extensive lecture. And aside from the mechanisms of drug resistance that we all know already, like drug inactivation, increased efflux of drugs, increased DNA damage repair, deregulated apoptosis, and tumor cell heterogeneity, we've been walked through by Professor Ankathil on the new molecular targets like the um, epithelial mesenchymal transition and tumor microenvironment, epigenetic alterations, and even microRNAs. So welcome, Professor Ankathil. And I'd like to throw the first question. In most cases, would it be possible actually to predict when drug resistance would happen?
Sorry, can you repeat, please? I couldn't
Is it
hear
is it
properly.
possible? Is there an instance wherein we can actually predict when drug resistance will happen? Are there telltale signs aside from, of course, tumor progression?
Yeah, according to the latest technology, for example, using NGS, we can detect the circulating tumor DNA in the using non-invasive techniques from the even from the blood. So, from the circulating tumor cells or circulating tumor DNA, we can do this NGS analysis and see which are the genes that are associated with the resistance. So that will give a, if you are doing that quite early, we can predict whether if you give a panel for resistance, we can apply that later. First of all, we have to identify the panel of gene mutations that are associated with the resistance. For that, we have to still do a lot of studies further and identify the panel of genes associated with the resistance. Once we establish that panel, in future we can do that for a prediction also.
As you mentioned about the liquid biopsy in NGS, and then detection of circulating tumor cells, and even the what do you call this, ctDNA, is it, should we be doing a baseline um, detection of your CTCs and your ctDNA. And then when the patient progresses, for example, you see the tumor markers, for example, in colorectal cancer, the CEA is increasing, you must also do another NGS, I mean liquid biopsy, to detect those? Should
No,
we be
actually no
doing
need.
multiples?
Sorry, first of all, we have to identify the gene panel. Then for that you have to use the NGS. So once we identify that, we can look for these gene mutations using another technique known as digital PCR. It is very less expensive and more accurate compared to NGS. So first of all, we have to explore using NGS and see the broad spectrum of mutation associated. Then after that, for further monitoring, we can use the droplet digital PCR. And for the problem with the droplet digital PCR is that we'll be looking for the known mutations. Whereas in the case of NGS, we can see the known and unknown mutations. So once we know the mutation specific related to that resistance, then we can proceed with for serial monitoring, we can proceed with digital droplet digital PCR. So that gives the concentration of the mutations. So that will be easy.
And more affordable, of course, than that's more affordable, of course, than having to repeat the detection of ctDNA and so forth. That is more affordable, and that's even a relief.
Yeah. Digital PCR is less expensive compared to NGS.
Right.
So as far as patient utility is concerned, droplet digital PCR will be more beneficial.
True.
So what I suggest is it should be a combination of NGS. Initially, we start with NGS, and then for further serial monitoring, it will be better we resort to droplet digital PCR.
Okay, got it. And Professor, you have mentioned about a new molecular mechanism of drug resistance, like the EMT, epithelial mesenchymal transition. And if I remember correctly, reversal of EMT is one of the mechanism of action of eribulin, halaven. Is there another common chemotherapeutic agent which works the same as eribulin in terms of reversing the EMT? Do we have in the market like a drug which can reverse the EMT as what eribulin or halaven does?
Sorry, I cannot hear properly. There is some disturbance from outside here.
You mentioned about a new molecular target for drug resistance is EMT, epithelial mesenchymal transition, right?
Yeah.
And if I remember correctly, eribulin or halaven reverses the EMT. Is there another common chemotherapeutic agent which can do the same, reversal of EMT?
That one I'm not aware of that. Sorry.
All right. Do you have any last words, Professor Ankathil? Because we don't have any more questions in the chat box. Any last words for our audience?
What I can say is that still we have not completely unraveled the mechanisms of chemotherapy resistance because of the tumor heterogeneity. So still we have to go further a lot. We have to go further ahead and pinpoint most of the gene alterations associated with the resistance. Then only we'll be able to design new drugs which are able to overcome this resistance.
And with that, I would like to thank all of you for joining us in this session on chemotherapy resistance, new molecular targets. And thank you, Professor Ankathil, for this very comprehensive lecture. Have a good evening, everyone.
Thank you all for your kind attention, and thank you very much. Good evening. Have a good day. Thank you.